Okay. Yeah. Hopefully everybody is back. I've managed to grab a cup of tea and just get ready for the next session. Just checking if Lynn and Caroline, just put in the chat box if you're back, and then we can restart. Have we got everybody back? Well, wonderful. Are you happy to start? Okay, just tell me when you want to go on the next slide. So we've got Caroline and Lynn. They're going to do their presentation regarding patient safety, but focusing on as you know, one of the biggest elements of the PLOG was the discharge bundle, which we did a series of study days about. But this time we decided to focus on the patient safety, the risk assessment, because we know that's been the hot topic, especially now as we've been talking about the RSV surge. So we thought it's really important that, we really touch on this topic. So I'll hand over to Caroline and Lynn.
Good morning, everyone. I'm Caroline Locke. I'm the Respiratory Nurse Advisor for the London region, and I work for Air Liquide. Lynn is going to lead on today's talk about the patient safety, and I will chip in.
Is Lynn there?
She was a minute ago.
Sorry, I am here. Yep, I'm here. Do you want to move the slides?
Yeah, you want to introduce yourself to the group?
Oh, sorry. Hi, my name is Lynn. I'm one of the community neonatal nurses, and I used to work in London, but I made a move to Edinburgh, so I'm currently located in Edinburgh to join the community team here. And yeah, it's a pleasure to meet you guys, and I'm still going to carry on with PLOG for a little bit until they kick me out. Yeah. So when we started PLOG and everything, we wanted to speak about the assessment. Everybody had concerns why home assessments needed to be done, and a lot of the concerns that came up and what we should be concerned about. Everybody asked us about smoking. What do we do when parents smoke in your house? It's not like you can tell them to stop smoking, and it's not like, oh no, we can't send them home on home oxygen because they smoke in your home, because ultimately the baby still needs to be discharged. But we just have to find a safe way to get the baby home. So Caroline is going to be probably touching on a lot of it because she's done a lot of work on smoking cessation, and getting the parents in a way to get them to discharge home safely. Next. Caroline, these are all your slides. Do you want to carry on with your slides because you're more familiar with it?
Yeah, sure. Tendai, could you just go back one slide, please? Thank you. So whilst we do talk about smoking quite a lot in adult services, I think this is less regarded in children's services. And I have been asked in the just as recent as last week, why should we complete a risk assessment? We need to get to order the oxygen as soon as possible. And I still feel that perhaps some people may misunderstand why it's so important to carry out a risk assessment. So I thought it would be a good idea to put some scenarios together. And we are working on another document with paediatric smoking cessation specialist in London, and that this will be our next working group that will be looking at smoking and smoking in parents, but also smoking in young children and adolescents as well. So I thought a couple of scenarios would be good. So for the first scenario, if a parent is a known smoker and the child is going to be discharged home oxygen. So some of the things that came to my mind was, as a paediatric nurse discharging this child, should you be concerned? And what are the issues that you envisage? What sort of questions would you be asking the parents? And how would smoking in the home affect the child's discharge? And what do you think are the necessary steps required before that child is discharged home? So immediately to me, those are the questions that come to mind. Next slide, please. So when you complete a risk assessment, there are certain things I think you have to ascertain. Are all the smoke, so one of the things is the parent the only smoker? Are there anybody else in the household who smoke? And is there any visitors that come to the house that smoke as well? Where do they smoke in the house? Is it outside or is it in the home? Is it near the oxygen equipment that is going to be installed? Have you had that conversation with the parent about quitting? Are they ready to quit smoking? Since their child is going home oxygen, you know, they've got a lung disease, is the parent willing to give up smoking? And I think, you know, we're all now tasked to do very brief advice. Some I know with a level in adult service are probably level 2, but at the minimum, we should be asking parents, are they ready to quit? Are the families aware of the reduced benefits of oxygen maybe to the child if they are in a smoke environment? What sort of property is the home that the child is being discharged? Is it a detached house? Is it joined? Is it in a high-rise building? In London, we do have a lot of high-rise buildings, and as you all know, we had Grenfell, not that was smoking related, but you know, escape is important, and it's important to know how to get out of a property if a fire does start. In London also, a lot of properties are attached or joined to each other. So smoking and fire could affect not just the property, but those around as well. The other questions are, does the family understand oxygen enrichment? So oxygen as a medical gas is heavier than oxygen itself that we have in the atmosphere, and it can accumulate in clothing, it can accumulate around furniture, and that enrichment can cause problems with starting a fire. So while oxygen is not flammable itself, but it can make a fire burn quicker and faster. Is the home being visited by the community team? So are you doing a home visit prior to the child being discharged? Whereabouts in the house is the child sleeping, playing, etc.? Whereabouts in the house or the property is the child going to be around? So it's trying to know and find out where they are located. Have you thought about contacting maybe the fire rescue services? They can do things such as install smoke detectors. Are there any key workers like social services involved in the actual child's care or with the family itself? Does the housing authority have anything to say about someone smoking and actually having oxygen installed as well? Do they need to be alerted? I mean, I know this is probably in an extreme case, in extreme circumstances, but I think it's worth having those conversations. And so what sort of advice will you be providing as well to the family? Next slide, Tendai. Lynn, do you want to talk about this bit?
Sorry for the technical error. So as PLOG, we actually created a risk assessment form that we felt that the questions and the things that we look at in the home are super important. And so if you look at the form, you kind of want to know the type of property that the family are staying in. And then you want to know if, how do you actually access the property? There's some properties that they actually have 2 access, or they actually have a back garden where they can actually, there's a gate to go out to the road. So these are things that you want to think about. It's almost like an escape route if something happens. And then you want to know for the long-term ventilation kits, is the door big enough for the wheelchair to get through, for the buggy? And actually you want to think about the level, because if you live on level 4 and then you don't have a lift in your building, you're thinking about the oxygen. You would think about the patient going up and down the stairs, and then if it's safe, the kind of equipment that you actually want Air Liquide to install in a home. So you'll be thinking about concentrator instead of having big cylinders in the home. So these are the things that you need to consider when you do a risk assessment. And then there are things that the parents should know, like home insurance. They need to notify their home insurance. And then you want to be just having a general look into their home. You want to know how many bedrooms they have. You want to walk around in a home to make sure that they have a smoke alarm. You want to go in and see their kitchen. You want to know if they have a gas cooker or an electric cooker, so that you can give them the appropriate advice. Because if they do have a gas cooker, obviously the child cannot be in the kitchen. Yeah, because oxygen and fire, they are not a good mix. Yeah. And then you want to think about electricity. If you have a concentrator in a home, you don't want the parent to have in the olden days, they still have to top up. And those are dangerous because in the middle of the night, if they ran out of credit, then you have no electricity. So you can't actually generate a concentrator if you have no electricity. So you want to consider all these things when you want to install oxygen in a home. Yeah. And then you want to think about, do they have a good working smoke alarm? Do they have a carbon monoxide alarm? And if they don't, you can actually call the fire brigade to make an assessment. And actually, if they don't have one that is in good working order, the fire brigade are happy to install one. And then you want to think about heating, because when you think about heating, you're also looking around in a home for damp, because damp and molds and oxygen don't actually mix. Yeah. Next slide, please, Tendai.
So this is a scenario for advice to parents. So I think some of the advice that we provide to parents is never smoke or let anyone smoke when using oxygen equipment, as the most serious incident involving the use of oxygen is caused by smoking, which can cause fires and burns. We treat e-cigarettes, which have a heat element, as the same with the same hazards. Smoking can also contribute to the deterioration of health to self and those around, including the child. As discussed earlier on, oxygen enrichment, parents aware that the build of oxygen can go unnoticed because it's colourless and not visible. And when oxygen is not in use, it should be turned off, as there's a greater risk to fires if it's saturated in the clothing, bedding and the furniture as well. So ask yourself the question, is it safe to discharge this child home? So I think one of the key things is talking about smoking cessation. If smokers are engaged, are willing to quit, does the smoker know where and how to seek help and to quit? We know that smoking cessation has now been reduced in funding, and it's actually trying to signpost, ensuring that we as a team understand where we can get that help, and we can actually signpost parents as well. If they're not ready to engage, then do they understand that they need to smoke responsibly outside the home and not within the home where oxygen is installed and used? Do you, as a team, offer very brief advice to parents, family, and even to children? We did a brief survey the early part of this year, and this was to adolescents, and there were a lot of children, we realised, that do smoke, and not just smoking cigarettes, but also illicit drugs as well. So it does matter to ask the questions to all those within the household. Are you trained on very brief advice? And do you have level 2 smoking cessation? Do you offer smoking cessation in your trust? And if you don't, why not? Next slide. So also within that risk assessment, if you are satisfied that the child can go home safely, do you carry out follow-up visits? When you enter the home, is there a strong smell of smoke? Have you noticed or witnessed any smoking paraphernalia in the home? What should you do? How should you address it? And who do you think should be involved? As a minimum, offer smoking cessation. If smokers are unwilling to attend smoking cessation, encourage responsible smoking. Uncover any other concerns within the home. Are there any safeguarding concerns? Consider an MDT meeting. If there is smoking and you want to raise it as an investigation, you can raise this through Air Liquide as a serious incident. Decisions to leave in the oxygen in situ and continue to monitor, if that's what you do, and ongoing concerns uncovered by Air Liquide from their 6 monthly service can be escalated back to the clinician as well. Next slide, Tendai. The MDT should involve, but is not limited to, the following types of people. So it could be your consultant, your respiratory nurse, a GP, fire rescue services, trust risk managers, Air Liquide respiratory advisor, social services, CCGs, and housing if appropriate. Do you have the full picture? If you're in secondary care or tertiary care, do you know what's happening within the community? So it's actually understanding what's happening within the home as well, not just from a secondary or tertiary care perspective. Next slide, please. Other things that could be a risk in the home, which can cause heat and burns, and that's looking at sort of naked flames, barbecues, candles, birthday candles, lanterns. People burn candles for religious ceremonies and incense. Household heating, as Lynn mentioned, gas fires, log burners, oil fires. Outside, other risks are bonfires, patio gas, and flammable materials. Is oxygen kept near them as well, such as petroleum, spirits, paint thinners, things like creams and aerosols as well. Other accelerants are oils and greases and lotions, so they can all easily ignite.
Shall I take over?
Mm-hmm.
So just like Caroline said, yeah, in her previous slide, and when you make a home assessment, you're able to actually see things that takes place in the home, whether if they have all this flammable stuff in the home, and you're able to give them the advice when you're physically there, telling them that actually these are flammable and probably shouldn't be in the property. So hence a home assessment is essential before you actually order the oxygen, yeah. And then when you're in a property, like I say, you're thinking, you know, you're checking for molds, you know, you're checking for funny smells of damp, because all this makes a huge difference to the neonate, or when you put in oxygen, it just concentrates it, and then it actually makes it worse to the respiratory status of the infant. And these are things that you should know. And if there is mold, you know, that you really need to resolve it before you actually install oxygen in a home. And then you want to think about the safety, that they have actually a good working phone, that they can actually contact Air Liquide so that they can actually reorder their supplies and their oxygen, and they can call their community neonatal nurses or community team if they need to for advice. And then you want to notify them that they need to tell their car insurance, just to notify. It doesn't actually increase the premium, but you do need to notify your car insurance that you'll be carrying ambulatory oxygen in your car. And then you're thinking about fire safety in the home, as Caroline mentioned about e-cigarettes. And then I had a discussion about pets as well in the home. One of the consultants actually asked me, what do you do with the pet when you see like 3 dogs in a home, you know? So these are things that you need to consider when you're putting oxygen in a home, you know, whether if you want them to put a 25-meter tubing in a home when they have 3 dogs, or dogs that would chew in the tubing. So you just You need to be wise. So hence a home assessment is definitely necessary. Next slide, Tendai. And then you want to think about traveling. We have a lot of families in London who don't actually own a car due to the ease of transportation in London. So you want to think about, if they're taking the bus and then the tube and then they're walking 15 minutes. So these are things that you want to think about before you order the oxygen. So if you generally know how the family live, you kind of know what to put in the home and what would suit the family and the type of cylinders that they will need, because there are different types of ambulatory cylinders that you can actually request for. And then if they do drive, they're eligible for a blue badge application, which actually should be done as early as possible, because some council can take up to 6 weeks before they get their blue badge. Yeah, and getting a blue badge is easy for them for hospital appointments, GP appointments, and some of the neonates have a lot of hospital appointments, even surgical appointments in different hospitals. So the blue badge will really help them, and then they can park in the hospital or nearby, and they don't have to drag the oxygen cylinder and the baby and walk 15 minutes or more. Yeah. And then you want to think about the support that the family have, whether if they have aunties and uncles, mom and dad who can help them. And then you're thinking about training as well, because a lot of family have a second, they go away to their parents' home, so they spend a weekend there. So you want to think about installing oxygens in the second home, and you want to think about training the family members as well, or other family members as well. And then you want to think about, do they actually speak English? Do they understand everything that's being told to them? Yeah, so you want to make sure that they fully understand. And if you need an interpreter, get one. Okay. And then prior to discharge, obviously you need to get to know the family. You need to get to know the plan that the child will be going home with. Because if you're taking this child home, you want to know what the hospital has planned, what they have said. And a good discharge planning meeting will actually ease the process from transition from hospital to home. And then it also reduces the anxiety of the parents when they have met you and your team. And then lastly, you need to think about, do you really want to put oxygen in this home? And if there are any things that you could actually improve on, if they didn't have a smoke alarm, get one in. If it's extremely cluttered, advice that you can give, maybe start decluttering before the child comes home. And you can actually give advice on where they can actually safely store the oxygen as well. Okay, next slide.
That's the last one. Yeah. So thank you very much, Caroline and Lynn. There was a few case studies, but we're going to circulate the slides anyway. I would really encourage you to have the opportunity to look at them. Caroline put a few case studies, which I really would recommend, with scenarios about GPs asking yourself the question that she's been highlighting earlier on at the beginning. So I would really encourage that you have a look at those slides when we circulate them, and the challenges that you might face, and things that you need to consider, about children if they're in school. And they're going to touch actually the school bundle next. So actually that would just flow well as we go into the school bundle. So thank you very much, Caroline and Lynn. Because of time, I would like to allow the other speakers to join. But I've noticed in the chat box, people are asking, where's the risk assessment? It's all part of the discharge bundle. You can just go and you can actually select which pages to print, and you can just print it as part of the discharge bundle. Really encourage that you use it. So we're going to go into our next presentation, which is about the school oxygen, the school bundle. So I'm handing over again to Caroline.
Thank you, Tendai. I worked on the school oxygen bundle with Tyree Rawson, who was in London, in northwest London. She's now moved to Manchester, and unfortunately she hasn't been able to have the time off today to join us for the study day. So I will present on her behalf as well. Next slide. So we came about I think about 3 or 4 years ago, I was doing a lot of chats and talks in schools, and unfortunately, it has been a very difficult process to try and get a child into a school environment or educational setting due to many misunderstandings and confidence issues around having children in a school with oxygen. So with this problem, we started to look into why this was a problem and to try and bring together something that we can actually present as PLOG members. So one of the first things we looked at was the legal responsibilities and duties, and the supporting pupils with medical conditions policy, which has been created by the Department of Education, contains statutory guidance around non-statutory advice, and this highlights people with medical conditions should be properly supported to enable full access to education, including school trips and physical education. And the governing bodies must ensure arrangements are in place to ensure the needs of the children with medical conditions, and that's oxygen is included because it's a drug, are properly understood and effectively supported. So with this document, we're able to then look at oxygen as its entirety to try and support pupils being admitted to school. Next slide, please, Tendai. So one of the key things was I put together an audit, and from this audit we were able to find the key findings. This has been recently submitted to which forum did I submit this to? I can't even remember. So we submitted this to a nursing forum, and we're waiting feedback to see if this is going to be presented. So the key findings is that there were 540 children, and I called them CYPs, with children, young person of school age on home oxygen. 16% of these children have a hoof with no activity. 41%, that's 233 children of school age, have not had their prescription reviewed or updated in the last 5 to 10 years. So this goes back to the question about the annual reviews. And on the broader issues within the service related to a lack of pathways and guidelines. So one of the key things was looking for some pathways for children going into educational setting, and there wasn't any sort of pathway that I could find. So with this in mind, we created this document. Next slide, please. So the aims and objectives was to provide information around the safe usage and storage of oxygen in an educational setting, to support the schools with a risk assessment, and to provide appropriate training to the non-clinical staff. So that could be school staff and teacher trainers who are responsible for the overall care of that child. And the objectives was to that the child who requires oxygen is fully supported in the school, and the staff within the school and the clinical and non-clinical staff are able to practice safe use and storage of oxygen. Next slide, please. So non-clinical staff undertake training to achieve the necessary competencies for supporting that child, taking appropriate steps to support the child with that medical condition, able to administer the oxygen correctly according to prescription, and knowing how to respond to that child if the child required medical attention, but also ensuring that the school records and medical records were kept up to date as well. Next slide, please, Tendai. So one of the key things was setting out a best practice document. So this dictates setting up, we felt that by having an account at school, not taking the oxygen from a home environment was probably one of the key factors, and therefore the main people who oversee the oxygen, such as risk assessments from Air Liquide, for instance, is undertaken at the school environment rather than just taking oxygen from home to the school. But also the fire rescue services, whom we alert for all new accounts, is aware that oxygen is within the school. So setting up a dedicated account with the oxygen suppliers such as Air Liquide in the school. This ensures that there is a registered oxygen within the school. the healthcare professional who will set this account up, and therefore the proper training is provided to the non-clinical staff. The child's own supply is not depleted, and also the school has overall control over the safety, storage and uses of the oxygen equipment. The oxygen supplier will also carry out 6 monthly maintenance and risk assessments, and the educational setting is able to replenish and make sure that they are keeping records of the oxygen that's been used. This ensures that the fire rescue services is alerted, as I said earlier on, and the risk can be managed at school. Next slide, please, Tendai. So, are you a Part B prescriber? How often do you prescribe oxygen in a year? And do you update these are the questions to the paediatric services, the child's hoof. Is this done by you, or is it done by secondary care? And do you find this process straightforward? And how often do you update the hoof? And who oversees the oxygen? If they're not on your caseload, what happens to these children? And do you look at the data that Air Liquide provides you on the Part B portal? I think some of these things that we were asking earlier on. Next slide, please, Tendai. So I'm not sure this slide is for this particular presentation, Tendai, but I'll ask the questions anyway. When was the last time you updated your training? Do you feel competent enough in the way you prescribe? Do you feel you have sufficient training opportunities? Is there anything that PLOG can do to support that as well? And how often do you think oxygen training should be provided? The questions I ask is, do you currently have oxygen dependent children in your CCG that attends an educational setting? And who provides the training to the educational setting in your teams? And how often do you provide oxygen training to schools? Do you have a school nurse in your team? What is your experience? Because I think that one of the key things that we found was there was always some reluctance from a school, because there was probably somebody who may feel that there was more risk than actually perceived from oxygen itself. Oxygen is safe if it's stored and monitored correctly. And I feel that sometimes, the delays to children can be quite enormous, and it affects their education if they can't access the school. So this document was really very much to support those children who are unable to access school because of the fears that sometimes was seen by schools. We find that sometimes that the same challenges come across each term, and the establishing a placement for these children can be quite time consuming. And because of this, there are delays and refusals to admission to these children around the safety aspects of oxygen within the school setting. Next slide, please. Thank you, Tendai.
Thank you, Caroline. I think it's just to highlight the question that to just prompt you as you're using the school oxygen bundle. It can be downloaded on the PLOG website, and it's got all the sessions, the checklist on there. It's got all the things that you need as you're leading that service. Either you're the named clinician, or maybe you're the named community nurse, and you're trying to think, where do I start? How do I get this right? So there is a checklist as you download the school bundle from the Pediatric Penn London Oxygen Group website that you can just be able to use, or you can hand over if there's groups of teams that you need to make sure they're doing it right. So thank you, Caroline. And I'll hand over now to Alison and Lynn to just give us the presentation about the home oxygen weaning guidance.
Thank you, Tendai. Hello, my name is Alison, and I'm a senior nurse with the Greenwich and Bexley Children's Community Nursing team. I'm also the designated oxygen champion and the go-to person for training, ordering and reviewing oxygen in the home. I'm going to give you a background as to how the weaning guidelines were developed, and Lynn will give you a tour of the weaning calendar. Oh, Tondo, the slides have disappeared. Yes, thank you. So just going to give you a background of how the discharge bundle was launched. So in 2018, the PLOG Home Oxygen and Discharge Bundle was launched. And this was feedback from PLOG members on study days, which highlighted the need for paediatric home oxygen weaning guidance. In 2020, PLOG created a subgroup that only focused on reviewing current literature around weaning children and young people from home oxygen therapy. A survey was conducted to investigate how the community teams across London are weaning children off home oxygen therapy. This also identified there was a huge variation across London and indicated a significant number of trusts did not even have a standard weaning guidance for carers and staff to follow. Next slide, please. From the literature we reviewed, there was found to be a great variation in practice guidance when weaning off home oxygen therapy. The variation was in healthcare settings, and this was depending on the services or the organisations. We found that there was no clear guidance or a lack of structured pathways for the weaning of home oxygen therapy for children. This has been a big challenge faced by children's community services, and it's the lack of agreement amongst health professionals regarding indications for prescribing home oxygen. Next slide, please. So PLOG conducted a survey and it discovered that across England, some teams started the weaning programme based on the named consultant direction and following the first outpatient review. And this was found to have caused a delay in the weaning process due to the availability of the consultant to discuss weaning plans and each consultant having a different guideline, causing confusion. In some geographical areas, home oxygen was independently started by the named community nurse within the home setting, according to the readiness of the child, based on various assessments. Next slide, please. The literature review and survey results discovered that in study one, this was a medically led study, that one group was seen in clinic monthly versus the other group did all the recording from home and then sent the data for review with feedback within 48 hours. Both groups were reviewed by a senior medical doctor. Again, this may cause a delay in the weaning process and may not be saved if there was a problem in the pulse oximetry. In study two, there was shared responsibility between the nurses and medical teams, and this was completed in a home setting and included a data recording that was downloaded by the community nurses. The review of the data was a shared ownership between the community nurse and the senior medical doctor, giving a faster response to the weaning process. Next slide, please. So, the common questions asked when an infant is discharged home on oxygen is, when is the right time to start the home oxygen weaning programme? What is the best evidence process to wean the child off the oxygen therapy? And what are the criteria to follow and who is clinically responsible for this process? Next slide, please. From a safety aspect, there was no uniform guidelines for weaning home oxygen therapy for infants, and there was only 8% specialist paediatric medical nursing teams who had a standardised weaning guideline. Where there was a weaning guidance developed, it could take a long period of time to completely wean the child off of oxygen, particularly if it was consultant-led. An average of 10 months to wean a child off home oxygen therapy, and at least 32% of the children identified had non-medical supervision during the weaning process. Unsupervised oxygen weaning, if not done safely, could lead to developing pulmonary hypertension or bronchopulmonary dysplasia in infants. And when not done safely, there is some associations with high mortality rates in children that can rate between 14 to 38%. Next slide, please. With specialist input and supervision during the oxygen weaning programme, most infants can successfully wean off the oxygen in 7 to 9 weeks. An infant that had monthly clinical visits, it took an average of 74 days to wean off home oxygen, versus when it was recorded using a home oximeter, it took an average of 53 days. And before implementing a trust guidance, it took an average of 21.75 weeks to wean off the home oxygen, versus an average of 8.75 weeks once the home oxygen weaning guidance was implemented using recorded home oximetry and the team downloading and reviewing the results. Next slide, please. So the benefits of home oxygen therapy is that it improves respiratory control, it helps to reduce apneas and episodes of desaturations, and decreases the amount of time spent in periodic breathing. It is beneficial in the child, especially infants with chronic lung disease, and oxygen therapy enables the infant to have reduced work of breathing, therefore enabling some level of growth that is similar to healthy term infants, and it's identified to improve neurodevelopmental outcomes, resolve pulmonary hypertension, and reduce risk of sudden infant death. Next slide, please. So the aim of the weaning guidance is that it is evidence-based, and by working together and sharing the experiences of respiratory clinical nurse specialists, community children's nurses, and community neonatal nurses. The families are also supported with evidence-based information such as leaflets and posters. We ensure that it's effective, and this will be assessed through auditing the guidance every 3 years or earlier based on new policies or evidence-based practices. We'll ensure that it is safe, ensuring that staff, carers and families are educated in oxygen administration and the weaning process. It will also ensure that it is standardised within London and other regions in England. That includes tertiary and community settings. We will also ensure that it is timely, and that will help to avoid long-term health problems which can occur if oxygen therapy is prolonged or not monitored. Over to you, Lee.
Okay, this is probably the topic that everybody is interested in. I'm going to try and speak slowly because I can waffle through really fast, but I'm going to try and do it slow. And please do ask questions because both Tendai and myself are very familiar with this. And okay, so let's go. Let's start. Okay, home oxygen weaning. We actually recommend weaning oxygen from 0.1 liters to air, and you don't actually need to go down 0.1 to 0.09, 0.08. You know, it's just a little bit too tedious, and actually the parents do actually get confused with all the decimal points. So, and literature has supported this, that you can wean from 0.1 liters per minute into air, so there's no need to go further down. But obviously, when the children go on 0.4 liters per minute of oxygen, then you start weaning from 0.4 to 0.3 to 0.2 and then to 0.1. And then actually the literature has said that, you know, the way that we do this, we do it gradually and slowly and safely. And actually it averages about 33 days before they're weaning to air. Okay, next slide, please, Tendai. So this is basically just to support what I've just said. And when do you actually start weaning? It has to be a joint decision between the parents and yourself. And basically, you need to assess that the child is actually ready to be weaned off oxygen by making home visits to assess the child. So they need to settle at home when they come home from hospital. They got a nice routine going, and then actually the child is thriving, doing lots of lovely activities. Yeah. And then we normally wean, like if they were at 0.2 and then we wean down to 0.1, you need to do a sleep study to make sure that actually the child is managing in 0.1 liters per minute. And then you proceed from 0.1 liter to air. And then I usually leave it for 7 days before you do anything else. Just leave them for a week to get used to it. And then you start weaning them. So this is what the calendar looks like from if you're weaning, like even if you're weaning from 0.3 down to 0.2 or from 0.2 to 0.1. We made it really easy and simple. And basically we take into account the number of people in your team, you know, how many people can go out. We're thinking about holidays, sickness. And we're also thinking about the geographical area because a lot of us need to drive quite far away just to assess a patient. And then some of us don't really have the capacity, especially if we only have 3 people in the team. Okay, so we don't want to drive 1.5 hours just to assess this patient. So we made it as simple as possible. So weaning off that oxygen, a lot of people ask me, Lynn, what do you actually look for when you're in the home? What do you do in there, you know? And basically things that you're looking out for, you know, usually when I enter the home, I will put a saturation monitor quickly on because the literature actually says that the child will actually hit their lowest saturation within 40 minutes of starting into room air. So actually you want to spend quite a lot of time chatting to the patients, but you're looking at your saturation monitor at the same time. So, and then they discourage, but basically the BTS guideline discourage a single spot check on saturation. So it's not good enough that you're there and then you're at the end of it and then you just do a spot check. Oh yes, 98, 99%, we're good. But actually the duration of time that you were there, the child could have desaturated a little bit, but you missed it. So it's really important to get your saturation monitor straight on the minute you enter the house. So how would you do this from 0.2 to 0.1? So we just made it weekly, and because the child is still in oxygen, so it is actually pretty safe to just go pretty quick. So we thought we'll just start, you know, you just assess the child when you're there in the home, turn it down from 0.2 to 0.1, stay there for about half an hour and see what the child does. And then you also want to catch them during activity at the same time, because a lot of the levels of activity, including the feeding, especially the feeding actually, and it shows that they use most of their energy during those times. So you want to catch them during those times as well. And then we normally leave them for a week. If they're happy, leave them on 4 hours in 0.1 liter, go back the next week. And just remember, a guideline is a guideline and it's always dependent on your team capacity. Yeah, and then when you can go back in and then go back in the next week. And then if the child is doing really well after the 4 hours of being reduced down to 0.1, you would go back in and then you just increase it to 8 hours. Tendai, next slide. And then from 8 hours, it's literally generally the whole day the child is in 0.1 and then do another week of daytime in 0.1. So when the child wakes up, just go down to 0.1, and when the child goes back to bed, you put it back up to 0.2. And then the following week, you're ready to do a sleep study. Okay, and analysis of the sleep study is as Dr. Hazel has mentioned. Tendai, next slide. Okay, this is the part where there's a lot of flexibility with this calendar, okay? And it's basically up to your team and how they do it. Okay, but we put this up just as a guide. And on day one, if you go in, you would be there in the patient's home, take them off oxygen and see what they do. And don't forget, you need to stay there for at least 40 minutes because the first desaturation you'll see is usually at 40 minutes. So you want to stay there just about an hour for the first home visit to see if they cope. Yeah. And at the same time, when you're doing all these visits and you're slowly weaning, you got to make sure that the child is actually gaining good weight, continue to grow. Okay, you're looking at their work of breathing and you're looking at the activity, whether if they actually, are they taking an extra nap just because you've started to wean? And then mom will be telling you things like, he used to be more alert and he plays longer time, but now he's, at 20 minutes, he's just really tired. So that'll be the time and the cue where you actually need to stop. Yeah, stop weaning and wait for a few more days. Okay, so the calendar is pretty self-explanatory. Okay, you need to keep this short as well. So if you have any questions, definitely come back to us because both Tendai and myself, we've done a lot of work on it and we're really familiar. And don't forget, at the end of the study, the sleep study is the most important thing. Tendai, next slide. Next one. Next one. So during your sleep study, don't forget when you give them parents the monitor that you actually clear all the previous data, because when you download, you'll be kicking yourself if you haven't cleared the data. And we made this a simple chart because all that you wanted to know during is the activity in the night. So when the parents start the study, what did the child do in the night? Did he vomit? Was he feeding? Was there a nappy change time? Because these are the time that you want to exclude from your study. Next slide. And these are the important parameters to remember, and Dr. Hazel has already touched on it. Yeah, and basically the second part where it says time spent below 90% should be no more than 5% of the study, and the mean saturation has to be above 93%. That is extremely important, and even though some of the children do meet the parameters, but if you look at the entire data, you would have failed them because there are just way too many desaturations. And don't be afraid to say that the child has failed and then just repeat it again in 3 weeks' time, because ultimately you're trying to reduce pulmonary hypertension. You want to give them a good quality of life. And actually don't be afraid about the oxygen. It's okay to have it for a few more weeks. And actually it promotes growth and it promotes lung growth, and the outcome of the child is a lot better. I think that's it, Tendai.
Thank you, Alison and Lynn. Because of time, I won't allow any questions, but please put your questions in the chat box so that we can have Debbie's presentation. So I welcome Debbie.
Hello. Thank you. I'm a respiratory nurse with the adult community, and I'm the adult representative within PLOG, as Tendai is the representative from PLOG into the adult staff. Slide, please, Tendai. So we identified that there's a big issue with the transitioning period, both from neonatals to children's and from children's to adult services. Predominantly today, I'm going to be talking about transitioning to adult services for patients on oxygen. Next slide, please, Tendai. So there is some documentation out there. There's the From the Pond into the Sea, which is the CQC document from 2014. And also there is some NICE guidelines and some quality standards from 2016. There's also some transitioning stuff from the Queen's Nurse Institute and from the RCN. Next slide, please, Tendai. So these are the NICE quality statements. I mean, basically they're saying young people who move from children to adult services should start having their transitioning planned at year 9, so age 13, 14. And that they should be moved across to the adult services with annual meetings, and that they should have a named worker and to coordinate that care. And they should each meet the practitioner from the adult service. Young people who have moved do not attend their first meeting are contacted by the adult service. How many of you can put your hands up and say that that is what happens in clinical practice currently? Next slide, please, Tendai. So we're looking at these teenagers, we're looking at these children, young people, CYPs that are transitioning over from children's services into adults with an ongoing need for oxygen. Next slide, please. And although this is from Jackie Cornish, who was NHS England's clinical director for children, young people and transition. And she had said that although there were some shining examples of good practice in general transition, it's poorly planned, poorly executed and poorly experienced. There are enormous risks to the young people from disengaging, being lost in the transition progress, and they're at a very vulnerable age. It's working towards their becoming adults, making their own clinical decisions and the legal responsibilities. So it is a bit of a minefield at this age. Next slide, please, Tendai. So there are some episodes of good practice at Southampton Children's Hospital. They have a service called the Ready, Steady, Go transitioning programme, not specifically for oxygen, but for transitioning patients across. And they sort of understand how it can be quite frightening for these children. Next slide, please. And also Great Ormond Street, who across London is one of our biggest places with the children's oxygen, is they want to make it as easy as possible for each teenager. So we would expect these big tertiary centres to be better at this. So usually there should be a clinical nurse specialist or consultant that takes on that role of transitions coordinator at Great Ormond Street. But again, how many of you in your own practice can say that you have access to that? Next slide, please, Tendai. So managers and practitioners should be, recognise structural cultural differences between the services. Adult services are very, very different in what they have to children's services. We use different IT. We have different practices and guidelines to how things are accessed and organised. This can make it really difficult for them to fully engage. And also, if we've not got any idea of what the oxygen was in for in the first place, it makes it very difficult if we pick them up and we haven't had that transition. Let's run Tendai. So I've been an oxygen lead across 4 trusts for over 15 years. Up until we did the first PLOG training with the transitioning in it, I'd not had any transitioning patients been brought to my attention. I have now had 4. So we're obviously doing something right. And also with the Air Liquide portal, because we get to see who's on oxygen, we can identify teenagers that are coming across. But there are many young people on oxygen that haven't been reviewed, and that, we pick in patients up that have been on neonatal lung disease oxygen at 0.1 when they're 18 years old, and it's just sat in the house. So I think we can all work together and make this so much easier and so much better. And we were decided we needed to do a piece of work around that and to support everybody. Next slide, please, Tendai. So we need to start looking at them at the age of 14. We need to start planning for the transitioning. We need to engage with all the other people that are involved. And these were from 2016, but early transition planning is a legal requirement, but we know that it doesn't always involve everybody that it needs to do. Next one, please, Tendai. So again, this is just saying from the quality statements that they should be having an annual meeting with the adult services from year 9. It may well happen with different teams, but perhaps the oxygen service isn't considered in that or recognised that's out there. So I think, again, that's just to make sure that your oxygen service is aware that this patient's transitioning over to them. Next one, please, Tendai. So we need to get people to meet, and it's important that the children know, or the children, young persons, know who they're going to be working with. And as I say, it's very different service. You would start coughing. So we need to build up their confidence to reduce the anxiety that for them and for their parents of coming over as a completely different set of people with a completely different rationale. And the child's life is going to be changing. They may be leaving school, they may be going to university. There are so many things to take into consideration. Next one, please, Tendai. So what we have to do when we look on the nice pathways is you've got a person aged under 25 is what they say for transitioning, but you're looking at your supporting infrastructure, your overarching principles and support before the transfer and again afterwards, so that this is a nice pathway that they know what's happening, things are being reviewed properly, and it reduces their anxiety. Next one, Tendai. So, as we've said, there may be communication between the medical teams, but often the oxygen isn't handed over to the adult services. Perhaps it's not realised that the adult services are out there, and across London, nearly every area, I think there's only one now that doesn't have an adult service. Often the oxygen has not been used for some time, staff move on, things change, it's in the cupboard under the stairs and it's been completely forgotten about, and it's still there. You need to know who the oxygen team is in your area. So this was one of the challenges. And do you get any communication about your paediatric oxygen data? As an adult service, I get data that comes through that tells me who's started oxygen, who's new to oxygen, who's come off oxygen. But I don't know, does that get shared with the paediatric services? We try and meet hours regularly, but it is a bit haphazard as to when we managed to do so. Next one, please, Tendai. So what do you do in your area? Do you have contact with your oxygen service for adults? Do you review your patients regularly before they transition over to see if they actually still need that oxygen? I think there's a lot to be thought about and a lot of service improvement and quality improvement that we can do with this. Tendai, please. So how do we get better? How are we going to improve this? And every single one of you will have different ideas of what we can do. Somebody's just asked, Laura's just asked about the oxygen service. No, not sure supplier, but within your trust or your area, you will have an oxygen service from the NHS for adults in each area. And I'm just going to go on and then I'll explain a little bit more, Laura. How can we get better? Next, oh, she's done it. So we developed the Oxygen Paediatric to Adult Transitioning Approach. So this is a document that's looking purely at the oxygen transition, but it also goes right the way through the pathways of how you do it, what you need to do. And at the back of it, there is a list of every oxygen service across London. So what you'll be able to do is, if Laura wanted to see, I'm picking because you asked the question, but if you wanted to see who your local HOSE are, we call them, home oxygen service and review, if you want to have a look who yours is, it will be there with the email and the telephone contact if we've got it on the back of that document in the appendices. So we're hoping that will make it a lot easier for people. There's also quite a few things in the appendices for you to look at and complete for the child to for the teenager to fill in, for you to fill in, to make sure this oxygen is either reviewed, discontinued, or that this adult services know why it's in and what the needs are. And also we need to think about if the child is finished with their education, and we talked about having oxygen in school, we need to make sure things like that are removed if they're no longer required. Next one, please, Tendai. So this is our transition checklist with your child on. So we will be looking at your current flow rates, current hours of usage, what equipment they've got there, because we use different equipment in adult services quite frequently. Is it still needed, or can we get it removed? When was the hoof last updated? Is the equipment still appropriate? Does it meet the needs of the child or the young person? And does that young person know how to look after their own oxygen? because assumably up until they've reached this age, mum or dad or carer has looked after the oxygen for them, made sure the equipment's serviced by the Air Liquide or across London, know how to change the filters and things like that. So those are things we need to see if this person who's now becoming an independent young adult, in many cases, knows how to do these things. Have you identified who your team is and have they accepted it? I saw someone there's just saying they're having big issues getting adult services to do that. But if they're 18 years old, then they become an adult patient. So it's getting that engagement. So your adult services, it depends on how they're very much on how they're commissioned as well. I don't know Wiltshire well. So you need to do a letter to hand over this young person. Can they communicate? What are their cognitive and communicative skills? Do they need interpreters? Do they need different ways of communicating? And do they know how to order their own oxygen refills? Do they know how to contact their supplier to order their own oxygen? Next, please, Tendai. So we did a pathway to make it easier. So transitioning, so current oxygen, is it still needed? Yes, then we do make sure you've updated the risk assessment form, you've updated the HOOF, and you contact your local HOSAR to hand over that your child or young person, and that they know how to contact the patients or know how to contact their oxygen service for adults. If they don't, is oxygen still required? No. Well, then we need to remove it. But that's communication. You will need to explain why you're removing it. It can create quite a lot of anxiety when we try to remove oxygen. People like it in a just in case, but that's not appropriate. So we need to find a way of communicating and working with the parents or working with the young adult. Next one, please, Tendai. Oh, this is my last slide. I quite liked. Oh, go back. Don't call me a teenager. From now on, I wish to be referred to as a pre-adult. I thought that was just quite a nice slide to finish on. There have been a couple of questions about identifying adult teams locally. And I see that we've got someone that's offered to help with that. Thank you so much. And it is sometimes it's the networking in meetings like this as well to find out who can help you. If there are any more questions, I think my time is up.
Thank you very much, Debbie. Yes, we're only left with 3 minutes. We were hoping to have, some open opportunity for discussion, but I've noticed that we've got a few people helping us on the chat. So Evan as well is part of PPLOG. So he covers the southwest of England, and we did some study days there when we went, and we were joined by Joe as well, who you saw is one of the authors of the reviews that we also did when we're doing the weaning guidance. So we've had that support. And I think it has been identified definitely in the chat box, because we've got an audience that is not London only. There is variation across England when it comes to home oxygen. We have definitely in London, there's been lots of work. And I think that's why it's good to have such a platform as this, because people are able to identify. We really encourage you, if you do not know your HOSAR, is try and find out who are your commissioning people as well. Who is actually commissioning oxygen within your area? Start speaking to your service managers, start speaking to your local, matrons. If you're a matron, start finding out from your service managers, because they will be the first point of contact to actually start getting involved, so that you know who's your home oxygen review colleagues. And then from there, you can then get invited to some of the meetings, so that you're able to actually highlight and escalate any issues regarding home oxygen. So I really, really encourage, that is some of the work we did when we're in North East London, was actually saying, I want to be part of the agenda. How do I become part of the agenda, so that you can hear and be part of that and actually escalate any issues you're having and then get those contacts. So we are rounding off. So thank you. I'm not going into that, but I just wanted to highlight that think about your risk assessments. Think about early planning regarding your children. annual reviews. One of the things to highlight that we will be circulating is that we're going to try and do some 30 minutes drop-in sessions monthly, because we know that this was just a webinar and we're giving you so much information. But we're going to do drop-in session monthly. We will circulate that so that people could ask as many questions over 30 minutes regarding anything to do with PLOG work. Maybe you might be trying to complete a risk assessment. Maybe you might be trying to do something else. I know somebody mentioned as well in the chat box as I'm about to close about perinatal, about mental health. There was some work we've done in the past regarding mental health of parents, about the stress they get when they're dealing. So we're putting that on the slides. So when we circulate, you'll be able to see that and just read about it and the challenges that parents feel. So there is lots of information for extra self-directed learning about the case study. So thank you very much. I do apologize, we couldn't capture as much of the discussion, but we will circulate the drop-in sessions so that you can come and ask those burning questions. You've got our contacts. Please feel free. Yes, Debbie?
Don't forget to go look at the PLOG website where you can find all the documents.
Definitely. And just please, we were supposed to put a survey link into the chat box. I think we didn't have time. So ask my team, we'll put it again in the chat box so people could actually complete the survey, and we could then circulate certificates for this webinar. So thank you again for joining us this morning into afternoon.
Thank you.
I'll ask some of the PLOG members to stay, please.
Yes.